do you use in your daily practice the do you check the biomechanical of the cornea, or before laser, if even surface ablation is for all technique, or just for LASIK?
Actually, I don't have the corpus in my center. I have the MS39, you know. So the epithelial mapping helps me a lot. But if I suspect, even with the epithelial mapping, I will send for corpus, but not routine. But epithelial mapping is routine. I wanna here. Let's see.
It's the same. I don't have it, but I have very easy access to it. I do epithelial mapping for everyone. But if it's suspicious, I may send it. But if it's suspicious, I don't touch it really. I have a literature. I don't do surgery. If I'm worried, I don't do surgery. As simple as that. Refractive laser. I could do implant if I'm worried.
Yeah. So my question to Dr. Ahmed about the evaluation of cases post LASIK. Do you consider the back surface or the front surface?
Personally, I didn't see a lot of ectasia, but I think it's from the back surface, because the failure of the cornea is from the back. So we have to check elevation map before to detect earlier the changes.
Also because if someone had decentered ablation, you may misdiagnose as keratoconus. So decentered ablation, you look maybe to you like keratoconus, but it's decentered ablation. So the posterior, always if it's posterior raised, means that's ectasia. Anterior is sometimes a bit borderline.
Yes, 5 years ago I have met Michael Bellin in India, and I asked him this question: in your bad display, do you trust it with the cases of post-LASIK ectasia? He said no. Actually, the changes in the pentacam and changes in the topography, the changes in the pachymetry and changes in the topography and the changes in the spatial profile of the corneal thickness curve will make it suspicious while be false. So check the back curvature and the back elevation is a clue for detection and diagnosis of the post-LASIK ectasia. Otherwise, if you have obvious case, during follow-up, the first presentation was good, but in the follow-up there is steepening, marked steepening in the surface with thin epithelium, not thick epithelium on this area. You can suspect and you can diagnose post-LASIK ectasia. Then go for cross-linking and think after. Don't wait. In the post-LASIK ectasia, it's not like conus. Don't wait for the follow-up. Cross-link and then think again about the coming procedures. So we have Dr. Olfa from Tunisia, and she's a retinal surgeon and a refractive surgeon as well. Anterior segment surgeon. You told me yesterday that you are retina. Okay, so did you see a retinal complication after laser surgery, after laser vision correction? Retinal detachment, retinal degeneration, retinal holes, or retinal or macular edema?
Macular edema could occur in after LASIK or refractive surgery because we don't touch the ocular barrier. If there is a macular edema after surgery, it should be Erving gas. So I don't think, in my practice, I never see that. But retinal detachment, I think it could be because the pressure of la notation, le session, Ahmed help me, session ring could, in theory, could elevate the pressure, and when we treat high myopia or middle myopia, they can have retinal degeneration, and we have retinal detachment. And the question is, if you do prophylactic laser, je sais pas, professeur Jabot n'est pas dans la salle. On lui poserait la question. In patient with degenerative retinal before surgery. Really, I don't do it. I don't recommend. Only if there is dangerous lesion as tears, of course. We don't discuss about that. But comment ça s'appelle? L'attestament, les palissades, voilà. Lattice degeneration, when we see that the retina is very thin and they could make a hole, I do it. I ask the colleague.
Thank you so much. But
one comment about it. There's a long time ago, there's a study show people retinal detachment is more with normal people than the patient who had LASIK. And the reason for that, because people had LASIK, they have retinal checkup. So if they have any retina, they're treated, and you don't have the retinal detachment. So it's not the laser make it statistic. That's the study, by the way. It's the other way around, but misleading. That because we examined the retina for this normal people, because the reason why they have detached, they are very high myopic. That's why they did laser surgery. And the reason mainly is really, but the pressure is controversial. There's no proving that the pressure will be a worry sign.
Yes. So the refractive patient, or the patient taking refractive surgery, is not only for refraction and then go for the OR. You have to check everything, including the retinal periphery. I have seen a patient in the last 2 months with